Okay, everybody, it's the 18th of July. It's the third Thursday. It's our quiz. I got 11 cases. Why not 10? Why not 12? I don't know. 11. These are some of the cases we saw in conference this week. I thought I'd share them with you. Study is done to rule out dissection. Aorta looks pretty good what you see, but what you see really impressive is a thickened esophagus. Thickening of the esophagus, you don't want to overcall or undercall, but if you keep looking at this case, on the sagittal and coronals, there's really significant thickening. You would even wonder on these images, perhaps, the patient has a perforation. Things, bad esophagitis, patients with chemotherapy, patients with alcohol abuse. In this case, I would even worry about a Boerhaaf's, right? With the air present at that point. Obviously, at times, severe esophagitis in cancer can look similar, but the extent of this, its involvement, the lack of findings in the abdomen, pushed me to really bad esophagitis. And this was due to alcohol abuse. And this is the kind of patient who can get a ruptured esophagus and a Boerhaaf's type syndrome. Okay, great case. Another case, chest pain, rule out dissection. Obviously, you see a mass in the sternum. We can look at it a little bit closer. Large soft tissue mass presenting as a mass in the chest or dissection. Patient had chest pain. You can see it very nicely in the sagittal view, the destructive lesion in the body of the sternum. There are also vertebral bodies involved. You can think about metastasis. You can think about a sarcoma, like a chondrosarcoma. But when you start looking at multiple lesions and a large soft tissue mass like that, you need to be thinking about a plasmacytoma. And this was a plasmacytoma of the sternum. Patient had myeloma with other lesions as well. Again, at times, chest pain. Yes, it is dissection. Yes, it is PE, but esophagitis. Bone lesions can all present that way, and that's why I showed both of those cases. I also showed a third case in conference was Takayasu's aortitis, where patient had thickening of the mesenteric vessels, thickening of the branch vessels off the arch, but presented with chest pain. So again, you got to keep your mind open when you're looking at these cases. Cystic lesion tail of pancreas. When you look at it quickly, you say IPMN, next case, maybe we'll get a follow-up. When you look at it more carefully, the wall looks a little bit thick. And when you change the windows, you can see it looks like there's some enhancement in the wall. When you see a cystic lesion in the tail of pancreas or anywhere with rim enhancement, you got to be thinking about a neuroendocrine tumor. Is it definitively neuroendocrine? Well, Mets can at times be necrotic and rim enhancement. MCNs, mucinous cystic neoplasms, can occur in the tail and have some enhancement or septations. I would have favored a neuroendocrine tumor in this case, but believe it or not, it was an MCN. But I think if you pick neuroendocrine tumor, I would give you 100% of the credit. That's what we all thought it was. Left upper quadrant pain. The patient has a large spleen pushing on the kidney. You could go through the differential of a big spleen from tumors to mononucleosis to thalassemia. Then when you look a little bit more carefully, the inferior aspect of the spleen perhaps is not enhancing as well as the upper half of the spleen. And as you go to venous phase imaging, you see that better. So maybe we're thinking infarction. This would be a pretty large infarct. You can see it nicely here and on the cinematic renderings where areas of infarction look cystic. So big spleen with infarction, well, of course, endocarditis, possibility. Mononucleosis is a possibility. And then you get into the other entities. What gives you a big spleen with infarction? Things like sequestration, patients with sickle cell disease, more sickle thalassemia, or thalassemia in general. And this was a splenic infarct with sequestration in a patient who had thalassemia. Great case. Patient had a routine abdominal aortic aneurysm repair, post-op not doing well. You can see there's a splenic laceration. There's actually active bleeding in the spleen. Now, this is a known complication no matter how you do the procedure, but it's not that common. But in patients who have drop-in hematocrit post-aortic repair, you always, of course, worry about the aorta. but you have to worry beyond the aorta. And here's a good example of splenic injury with active splenic bleeding, what looks like a splenic artery aneurysm, which had bled and is actively bleeding in and around the spleen. Just a really, really nice case. Okay. Right upper quadrant pain, right upper quadrant looks good. Multiple splenic lesions, patients immunosuppressed and febrile, candidiasis, aspergillosis. Doesn't look like cysts, it looks like numerous lesions. One of the things we know, and I've shown you a number of cases before, sarcoidosis can give numerous lesions in the spleen, can also occur in the liver at the same time. Obviously, you worry about small cysts, small hemangiomas, but it really doesn't look like it. These look like solid, small masses. And that's where the diagnosis of sarcoid comes in. You could look at the history, perhaps there's something in the chest, perhaps the patient has known sarcoid. Again, liver may or may not be involved. Just a really good example of sarcoidosis of the spleen. Pelvic pain, complex cystic lesions. Now, easiest thing to tell you it's a female, but I'll tell you it's a male. And if you look at the image on the right, that's a very classic cystic lesion, right? There's cystic lesions in the cystic lesion, and there's calcification. You look at this, you put it anywhere in the chest, abdomen, pelvis, it's going to be Hydatid disease. Here is the liver with one of the cysts densely calcified, another large cyst present. So look at that. Cystic lesions in the liver, cystic lesions in the pelvis, Hydatid disease. What a great example. And I was commenting yesterday, I had not seen a Hydatid so calcified, but it does happen. Okay, liver function tests and fever. You look at the liver, maybe fatty infiltration, pericardial effusion. You keep looking, there are masses in the left kidney, there is nodes in the paraortic region, there's funny enhancement in the liver on the arterial phase, and as you go from arterial to venous, you see evidence of what looks like a mass in the liver. So now I have fatty infiltration of the liver and a mass. It's not enhancing like FNH or hepatic adenoma or hemangioma, so I got to worry about a tumor. Again, look how subtle it is from here to here. But then, of course, when I see the renal lesions and I see the paraortic adenopathy, the renal lesions alone, though it's multiple, I could think of renal cell, but if you have multiple lesions, you can think of metastasis, including melanoma. You need to also be thinking about lymphoma. And lymphoma can involve multiple organs, as does melanoma, so that may not help you as much. But at the end of the day, this was a case of primary lymphoma in the liver with renal involvement and adenopathy. Lymphoma of the liver is a challenging diagnosis because it's often infiltrating, looks like fatty infiltration, but it's important to think about. Incidental findings, small right adrenal lesion. Now you may say, oh, it's incidental, it's small, it's a centimeter, blow it off. That's a thought. And it measures 45, so you can't blow it off. Under 10, it's an adenoma. 45 could be anything, so you need to give IV contrast. When you do, it enhances to 196. If the patient had a nephrectomy, you would say metastatic renal cell, that's a thought. But a small or even large adrenal lesion, very vascular, surely above 120 Hounsfield units, surely at 196, is going to be a pheochromocytoma. Look at the coronal views, how small and bright the lesion is. Just a wonderful example of a classic pheo. And again, you say, well, pheos are usually larger. They got to start somewhere, and this is a small one. Okay, very, very nice example. You can see how bright it gets despite everything. Okay, incidental finding. What are we talking about here? There's a lesion. Is that kidney? Is it adrenal? I'll tell you it's adrenal. There's some patchy enhancement. It's cystic. So what do you think about? Could it be an ACC? They can be. Primary adrenal cortical carcinoma can be cystic. It's not a simple cyst because it's a thickened wall. Prior hemorrhage is a possibility. You can see that the wall enhances a bit. There's some patchy enhancement in the lesion. One thing you always need to think about when you have a cystic lesion, particularly when it enhances, is a cystic pheochromocytoma. And yes, this could be an adenoma that bled. This could be a cystic pheo. This could be, in theory, a cystic ACC. This was a pheochromocytoma. Remember, we wrote an article, pheos have 1 million appearances and seemingly 1 million lives. Another case, suspected pheo, but the adrenals look great. Point and lesson. If the adrenals are good, you got to scan downward, right? You got to scan to the symphysis, because you may have a pheo in the bladder. You may also have a pheo or paraganglioma at the level of the organ of Zerkocandle at the aortic bifurcation, as you see here. Classic diagnosis. There's this relationship to the iliac vessels. Just a wonderful example, and there's actually several masses there, and the main mass. Vascular mass, organ of Zerkocandle near aortic bifurcation, which was a ectopic pheochromocytoma or paraganglioma, depending how you want to call it. And you can see, look how it encased the vessel, but with chemotherapy, and then potentially people have done that, but typically resection, which can be a challenge, particularly if the lesion is infiltrating. So pheo at the organ of Zerkocandle, that's Zerkocandle, not Zuckerberg like in Facebook. Again, classic location, organ of Zerkocandle. Well, that's 11 cases. That's it. I hope you like the cases. I hope you learn something from the cases. And I hope you come back real soon and check out all of our cases on CTisus, on the Facebook page, at the website, and everywhere in between. And with that, I wish you a great day.